Good morning. Thank you for giving me this opportunity to speak to you today on troubleshooting in ECMO. James gave me very short notice. So next slide. Disclosures. Next slide. Disclaimer. What I say here is my opinion, right? Next slide. So the contents of this talk would be part introduction. We'll talk about factor levels in the first 5 days of ECMO. Obviously, we're going to be looking at bleeding, thrombosis, some anticoagulants used in ECMO. Monitoring is important. My anticoagulation profile that I am using, my clinical approach, is anticoagulant-free ECMO possible? I'll talk about one scenario, and blood products in the end. Next slide. Next slide. So this is the ECMO pyramid. Well, we have a few things that we need to be addressing. The first one is age-related development hemostatic changes. And with age, a baby is different from an adult, is different from a elderly patient. If you're looking at variable effects of etiology of critical illness, are we looking at a patient with a cardiac problem, a pulmonary problem, a patient with cancer, a patient on anticoagulants, a patient with sepsis? And one of the things that we all know about in this room is the ECMO circuit. Are we using a VV-VA a circuit that's anticoagulated, etc.? So all of that is important to know when we make a decision to put a patient on ECMO and what the outcomes is going to be. Next slide. So we all know that 60% of our patients will present with bleeding during ECMO, but only 14% will have thrombosis. And ECMO exposes blood to a huge endothelial circuit that's free of any anticoagulant in majority of cases in the old days, in the 1970s. And this caused stimulation of the coagulation cascade and subsequently thrombosis. Now, anticoagulant medication counteracts coagulation activity, and most of the time we use unfractionated heparin. Now, the development of modern hollow fiber oxygenators, biocompatible coatings of the tubings, oxygenators, and the use of a centrifugal unit, we decrease activation of the coagulation circuit. Next slide. So the postulated cause of bleeding is loss of large von Willebrand multimers due to exposure to the high shear stresses. And this enhances cleavage of von Willebrand multiples by Adams TS13, which contributes to impaired platelets. It's similar as in TTP. We also get an acquired antithrombin deficiency that occurs with prolonged heparin administration. The other one is the raised factor VIII level, and this is found in endothelial cells, and the secretion increases with illness. We do know that factor VIII is important in the intrinsic pathway and in the kinase, and if we have an abnormal factor VIII level, highly elevated, a low antithrombin 3, we're going to have dysregulated thrombin generation, and this increases the possibility of a thrombus. Next slide. So what happens in the first 5 days? Well, all our procoagulants go up. Our anticoagulants stay on the low side, and we have this exposure to the ECMO unit that's stimulating procoagulant activity, inflammation from leukocytes, increasing in tissue factor exposure, and then subsequently a blood clot forming. Next slide. So bleeding, first of all, and as Jerome showed us in the first picture, once you cut into a patient, you're going to have bleeding. When you put these huge catheters into a patient, you're going to have bleeding. Is the patient just out of theater? Exhaustion of the coagulation system and a continuous low level of fibrinolysis can lead to coagulopathic hemorrhage. And this occurs in 20 to 33% of cases. Chronic blood loss will be associated with loss of coagulation factors and platelets, and substantial bleeding occurs in more than 30% of patients. Now, the majority of cases are non-life-threatening bleeds. We're looking at epistaxis, gum bleeds, some GI bleeds, maybe pulmonary hemorrhage. But then we still have 5 to 19% with major bleeds, and that's, we're looking at intracranial bleeds, which can be a problem to manage. Next slide. So, thrombosis can be found in the ECMO system, but more frequently it occurs after we decannulate the patient, presents with a DVT. In 20% of cases, we can find a DVT in the patient with not having any symptoms at all. So acute thrombosis of the oxygenator tubing occurs in 35% of cases and must be followed with changing of the system. Next slide. So to prevent these blood clots forming, we would use anticoagulants. And in a study or in a research survey, they found 96% of all units use unfractionated heparin as anticoagulant of choice. Its well-known mechanism is known, easy to antagonize and easy to monitor, APTT and ACT. We also use some low molecular weight heparin. But one of the issues with heparin is the development of HIT. It occurs in 0.5 to 5% of patients, and around about 30 to 60% of these patients would present with thrombosis. So once you have HIT, you would then have to use an alternative anticoagulant and use a heparin-free ECMO circuit. Next slide. So once we have decided we're going to change the anticoagulant, the majority of the time in our centers we would now start using fluorouracil, the last one on the line. And we usually base that on weight. Now 5 milligrams for less than 50 kg, 7.5 milligrams for 50 to 100, and 10 milligrams for greater than 100. Now we need to know that in a healthy young adult, the half-life of anticoagulant is about 17 hours. In that of an elderly patient, it's 21 hours. And now we're looking at a critically ill elderly patient on ECMO. We need to keep in mind that over-anticoagulation might be a problem as well. Next slide. So, what are the alternatives? Could we use low dose versus standardized dose of heparin to reduce our risk of bleeding, but still ensure that no thrombosis occurs? Yes, it can. In this study published in 2021, it did show that if you use a low adjusted dose of heparin or anticoagulant, you can have the same amount of thrombosis, bleeding complication as using a standard dose heparin infusion. Next slide. Monitoring during coagulation in ECMO. Well, we all know these are the common ones. APTT, activated clotting time, anti-fractionated assay, viscoelastic test, fibrinogen, D-dimer, antithrombin, hemoglobin, and platelet count. Now, not one of these tests can give you a definitive answer in the coagulopathic state of a patient at any one time. You have to use it in combination. And the way it's done is in parallel or in sequence, and we tend to analyze that. One of the tests that's not mentioned on this one is von Willebrand's. Now we do know you can get a acquired von Willebrand's. So do we have to test von Willebrand's on a weekly basis just to ensure that our von Willebrand level is fine? Now if we do have a low von Willebrand's, do we replace? We currently have an NBI product, hemosolvate, but it also has factor 8 attached to it. Now factor 8 would increase coagulopathic thrombus formation. Next slide. So monitoring, this is what was recommended in this 2018 publication, where they wanted fibrinogen, TEG, lysis, D-dimer, and antithrombin done once daily, twice daily hemoglobin and platelets, thrice daily APTT, ACT, and R times. Now, whenever you test patients on this, the problem is that every time you take out blood, you're actually lowering the hemoglobin, etc. So we have to balance the amount of tests we do versus the results we want. Now, obviously, once you start a patient on ECMO, you need to monitor frequently, and then you can adjust your duration of the testing so that you don't over-test these patients. Next slide. Now, I want to point out to you the common tests we use, APTT, and anti-factor 10A. So, the reference range that we are looking for an ACT is 180 to 220, APTT 1.5 to 2.5, upper limit of normal, and anti-factor 10A level 0.3 to 0.7. Sometimes when we do these tests, and it might fall in the acceptable range, but these patients can still bleed or they can form blood clots. Next slide. So this is an anticoagulation protocol that I use, and it was published in 2019, and it very quickly helps us adjust the dose of heparin infusion, whether we're looking at ACT or APTT, and try and keep the patient within an acceptable range. And it also tells us how frequently we need to monitor once we make a change in the anticoagulant dose. Next slide. So, clinical approach. Be familiar with the ECMO system. Knowledge if ECMO system is fully or partially coated. Create a system with a tubing long enough for practical purposes, but short enough to reduce contact surface. Pump plays a major role. If the blood flow exceeds 2 to 2.5 liters per minute, the chances of thrombosis will decrease. Patient comorbidities and current bleeding status. Patient medication is important. If this is already includes an anticoagulant or an antiplatelet agent. Next slide. So underlying disease could also interfere with the hemostatic system in some prothrombotic situations such as sepsis, autoimmune diseases, after childbirth or cancer. Monitoring should be increased in the beginning of ECMO run to adjust the dosage of anticoagulants. In cases with an increased bleeding tendency or the potential bleeding in vital organs such as brain or during cerebrovascular accidents or DIC, it is wise to withhold anticoagulation until risk is controlled. Now, anticoagulation and tests for monitoring should be available. Now, that statement means that you need to have these tests within an acceptable range of the patient. You can't have a lab that's doing an anti-factor 10A level in Johannesburg, and if you need a result, you need to fry that specimen. So it has to be local. Next slide. So, is anticoagulant-free ECMO possible? Well, we know we have this balance where we have lots of bleeding and lots of thrombosis. And it depends on the clinical scenario that the patient is presenting, and we can then determine if we can use an ECMO-free, an anticoagulant-free ECMO circuit. Next slide. So what we know is that high-risk population, especially those that have relative contraindications to ECMO, example, intracranial hemorrhage or other recent or ongoing bleeding, we can consider an anticoagulant-free circuit. Now, 3 systemic reviews have shown anticoagulant-free found no significant difference in frequency of thrombosis and bleeding. And surface modifications, broadly classified as surface passivation, biomimetic and endothelialization, are techniques used to mitigate the bioincompatibility of ECMO circuitry. Heparin-bound circuits and may facilitate anticoagulant-free ECMO. Now, in some of these studies, they showed you could go up to 4.75 days of not using any anticoagulant. Obviously, you prime your circuit, but after that, 4.75 days with no anticoagulant, and the results are similar in the anticoagulant versus the non-anticoagulant units. Next slide. So in this scenario, we have falling circuit flows on a VV ECMO. So a patient on VV ECMO stable with a saturation of 93% and a drainage saturation of oxygen of 70%, circuit flow is 6 liters per minute and a pump speed of 3,500. And over the last 12 to 24 hours, the flow gradually falls to 4.5 liters per minute despite increasing pump speed to 4,000 Rs per minute, and the saturation is now 87%. Obviously, we need to make sure that there's no change in the position of the cannula, there's no kinking of the tubes, there's no sucking on the or low volume coming into the circuit. But once we've excluded all of this, then we would have to consider a thrombus. Now, a thrombus would form in one of two places. Majority of the times in the oxygenator or the pump. In the oxygenator, if there's a difference in greater than 50 millimeters of mercury on either side of the pump, it then suggestive that maybe that the oxygenator is a problem. From a pump point of view, they say that you could hear there's a change in the pump itself. So if that's the story, then you would have to change the entire circuit and then move on. Next slide. So what if in case you have a bleeding patient and a clotted circuit? So patient on a heparin infusion rate required to maintain ACT between 180 and 200 seconds was increased to 10 international units to 30 international units per kg per hour. Now bleeding was noted at the vascular access site and thrombus noted in the circuit. Now two areas that we need to address is the apparent heparin resistance and bleeding and thrombus formation. Next slide. So if we have an ACT and an APTT in the therapeutic range, we have heparin resistance. We do know that antithrombin 3 levels do go down. If we have an anti-factor 10A in the therapeutic range and a low antithrombin 3, then we are dealing with heparin resistance, and it's easy to sort that one out. We'll just give an infusion of FFPs, maybe 10 to 20 international units per kg, mils per kg, and we'll bring up the antithrombin level. If we have an ACT in the therapeutic range and prolonged APT, then we need to think about a coagulopathy. Now, the coagulopathy could be easy to determine. We do a 50-50 mix. If it corrects, we know we're dealing with some sort of factor level that's missing, and we can easily replace that. If we know that we are now having a low platelet count and features of thrombus forming in the circuit, then we would have to consider, are we dealing with a thrombus forming in the circuit or a DIC kind of picture because of the thrombus in the circuit, or is it sepsis? Now, if it's thrombus in the circuit, we just change the circuit and we're back to normal. But if it's DIC, we need to aggressively treat any infections. So microbiology is important in these patients. Next slide. So bleeding and thrombus is suggestive of either heparin-induced thrombocytopenia, HIT, or DIC. So DIC may be triggered, as I said, by thrombus in the circuit or sepsis, but HIT, on the other hand, once we have a diagnosis, or if we use the 4 T's and we say, yes, this patient probably has HIT and the antibody level comes back as being positive for the HIT screen, then we can change our anticoagulant. Obviously, sometimes the circuit's got anticoagulants in it. So we stop heparin, change to Paranox, see how the patient does. If the platelet count is not increasing, change the circuit to a heparin-free circuit and then continue. But we do know that some normal patients not exposed to heparin can also have HIT antibodies testing positive. So the specificity of these tests is not so high. Next slide. So this is my last slide, blood and blood products. Now, in my readings on blood and blood products in ECMO, there's been talk about using a restrictive hemoglobin transfusion threshold. So whether you transfuse when it's less than 9, between 7 and 9, or greater than 10, etc. Platelet count 50 to 80. INR, if it's keep it less than 1.8. If it's more than that, you need to correct. Fibrinogen greater than 1.5 grams per liter. Antithrombin, some say less than 70%, others say 80%. Now, when we treat these patients, we're exposing them to blood. Now, from a consumption point of view, they say on average, a patient on ECMO would use 1 red cell concentrate every day, at the very least. Now, if we know our current SANBIS situation, we currently have probably less than 5 days of blood available for the whole country. So we have to use all our resources to try and limit using too much of blood in this patient, because this is not the only patient. We have lots of other patients as well, but obviously if it's clinically needed, you continue using it. When we give blood and blood products, we have to worry about TACO, Charlie, as well as antibody production, because if a patient develops antibody to platelets, no matter how much of platelets you give after that, the patient will not increment. So we need to think about that. Also, free plasma levels in the blood. If the plasma hemoglobin levels go more than 1.5 grams per deciliter, we won't be able to assess APTT and anti-factor 10A levels. So we won't be able to adjust our anticoagulants. So we need to plasma exchange. So blood products, important. Thank you.